So Clinton, you mentioned incisions. Let's hear it. Typical garden variety. Maybe if it's like extensive, super hilar, you can consider a chevron. Otherwise, limited midline.
Pretty much midline for everything. If you're looking at more early stage disease, I think we've progressively tried to minimize the impact of the incision, especially on left-sided tumors, because you can mobilize the colon and really limit what you have to do to expose that. And so usually it's about a handbreadth for me, right at the beginning of the belly button cephalad. I always tell the residents that you have to pay attention to the location of the belly button because it's not necessarily the same in every person. Some patients give you a really long distance. You always have to think where you get to relative to the orchiectomy site. If it's a testicular primary, if it's a retroperitoneal primary and you're not worried about resecting the gonadals, and it's not as much of an issue. But 99% of cases that we're doing, I'm always thinking about that distance between the caudal aspect of my incision where I need to be able to retract down to get down to that internal ring to retrieve the entirety of my spermatic cord. So